Our first speaker today is Mukesh Verma. I've known him for almost 30 years. He and I both used to work at George Washington University. And then he came to the Division of Cancer Prevention. And subsequently, he joined DCCPS in 2004 as a program director. And he became then acting chief of the Analytic Epidemiology Research Branch. And then in 2007, he became branch chief of the Methods and Technologies Branch. And so he's going to talk to us today about epigenetics. It's not just gene mutations. Gene silencing is very important too.
Thanks, Terry. So today I will be talking about epigenetics. This is a different way of gene regulation. So since I am from the Epidemiology and Genomics research program, so I will cover how this area is important and how we can utilize that to identify people who are at high risk of developing cancer, as well as how epigenetic approaches can be used in clinic. Few of the drugs have been approved by FDA, and what clinical trials are being done, and what is the mechanism behind epigenetics, how gene regulation occurs. So all those things I'm going to cover in the talk. So since I'm from Cancer Institute and we work on epidemiology and genomics, can you hear well all? Okay. So cancer, as you know, this is a serious disease in which prostate cancer and breast cancer in men and women, they are the #1 killers. And 1.6 million men and 2.2 million just with these cancer, they are affected. And this number is growing, although we have succeeded little bit in by screening and other method, that survival and quality of life is better. In 2010, it was estimated that 13.6 million cancer survivors will be there, but in 2022, we expect the number will increase to 18 million. And here, distribution of incidence like new cases and how much they survive in men and women, they are shown for different, especially for colon cancer or breast cancer. Screening have been very useful, as well as early detection markers have been useful in different cancers. Cancer is such a disease that for major cancers like breast, cervix, colon, prostate, lung, it takes many years to develop. And those stages which come at different times, those are defined there. So our idea is that if we can characterize or focus more on early stages, then we have more options for doing chemoprevention or therapy or other aspects we can do. Initially, when biology was developed, then genetics was developed first. So in that, some mutations in specific genes, and this is a model of colon cancer, those were identified. Some were for initiation, some were for pre-malignant stages, and then for invasive. And those kinds of information were useful. And based on that, and based on the age and other time, different terminology also you will see for breast cancer, atypical hyperplasia, DIC, and all that, and for colon cancer also. So that in genetic terms and in histological terms, cancer was characterized very much. Then came the technology when sequencing was more popular. It was called SNP characterization and then genome-wide association studies. What happens that those small changes in DNA sequence, whether we can link to the chromosomal location or not. So in 2005, basically, first GWAS was done. And these are different chromosomes. And as time passes by, for different chromosomes, different genes were localized, which were associated with not only cancer, with others also. So by the time 2008 or 9, for most of the chromosome location by GWAS, they were identified. So this is the situation. Now, because of that, we wanted to utilize that whatever information in genetics is there, how we can use that for epigenetics. So if you see in genetics, the way they have identified for different kinds of cancers and different anatomical locations, how many are there, where they are. Similar thing we want to do in epigenetics. In cancer model, basically 12 pathways which Vogelstein proposed, they are the major pathways. So that has also been characterized. Now comes epigenetics. So in genetics, you know, those are hereditary genome sequences changes or deletion or addition. But if without changing the gene structure, gene expression changes, that is called epigenetics. So we know about genetic code, and in epigenetics we have two codes, methylation code and histone code, and I will be discussing more about those. So in your mind you can think genetics will tell what you are capable of, but epigenetics will control when something you should be doing and when you should stop that. So that kind of regulation is called epigenetics. And by terminology also, epi means above, genetics. So what is above genetics? Time to time you will see in popular magazines some articles that your DNA is not your destiny because it was found that by changing behavior, lifestyle and other things you can change expression of genes, and in terms either you can reduce a disease or just can avoid that. And to distinguish genetics and epigenetics, some experiments were done in monozygotic twins where genetic makeup was exactly the same, but in that what was found that a lot of discordance was there, either in cardiovascular diseases or other diseases, and that's how epigenetics came. And in that they found that without DNA structure change, some changes were there. And that gave us the idea of epigenetic predisposition. Like if you see some epigenetic changes, that person is at high risk. Or the way pharmacogenomics is, like based on genetic background, people can treat. Same way, epigenetic background also, that is giving rise to pharmacoepigenomics or personalized medicine. And this year also one article came that cancer epigenetics are the driving seat, because now such changes people are identifying which are the starter point. When at a stem stage you are there are no mutations, SNPs or indel or any kind of changes. But gradually methylation changes or other changes, epigenetic changes, they arise. To give you a little bit background about chromatin, it is made up of histones, H2A, H2B, H3, H4. H1 is just a linker, and these are 146 base pair long, and they are attached to neutralize the charge of DNA and to stabilize chromatin. In promoter region, CG sequences are very common. Normally, this cytosine is there, but sometimes, especially in disease initiation, cytosine gets methylated at 5' site, and that can cause gene suppression, and it is observed in tumor suppressor gene. At the same time, some genes are such where promoter CG sequences are already methylated and they get hypomethylated, and that was observed in oncogenes. So for different genes, different kind of regulation is there. In epigenetic regulation, mostly components are either methylation, which is done by DNA methyltransferase genes. Number 1, 3A, difference are there. Some are for initiation of methylation, some are for maintenance. Histones are there, which get modified either by acetylation, methylation, phosphorylation, or other kinds. Then comes non-coding RNA, like microRNA and others. They also regulate gene expression. You will hear few terms also recently were introduced, like shorts and shells. Like those CG sequences, if in 0.4 kb region 60% CG sequences are there, they are called CpG Ireland. But if those sequences, CpG sequences, are less than 2 kb, then these are called shorts, and 2 to 4 kb, they are called shells. And other area is called open C. So these are the terminology, time to time they are coming. So regarding component of epigenomics, as I mentioned, methylation regulation is the main one, done by methyltransferase genes. Then comes histone modifications, compact chromatin versus relaxed chromatin. That is done by different modifications, acetylation, biotinylation, methylation, phosphorylation, ubiquitination. In between comes microRNA as well, and some non-histone proteins like polychrome group of proteins or chromatin folding proteins, they are there. For histones, different kinds of enzymes or proteins are there. That has been characterized. Now, some sequences are called repeat sequence, alu sequence or sign and line. They are very much involved in genomic instability. So they are important from that point of view. Genome and epigenome, when we characterize genome, since in all cells the same kind of DNA is there, whether you take from blood or lung or colon, you have to sequence only once. But epigenome is dynamic. So anytime you are doing longitudinally, many samples you have to take, that changes, and they work in coordination. And in monozygotic twins, many studies on different diseases have been done. In some diseases like neurological disorders and others, genetic component dominate, while in cancer and few other diseases, epigenetic influence is more. And they, like genetics, by diet or lifestyle or environment, epigenetic changes happen. Now, more important is that when epigenetic error can happen. So usually the order of error which can happen, that is quite early, before birth or after birth. You can see based on the weight or how many order of defects can happen early, and later on they are less. And in this figure, if you see that mostly at initial stages, maternal factors or environmental factors, those together influence for initiation of disease. Later on, it becomes mostly lifestyle and diet. So that's how they have defined. And at the same time, at different stages of life cycle, different kind of biospecimen or samples can be collected, which can be characterized for epigenetics. If you think about some pregnant women, then if that person is smoking, then mother's generation that is affected, then fetus, and then reproductive cells. So even 3 generations can be affected. And epigenetic changes are more susceptible than genetic changes. So at NIH, as such, or at NCI, we emphasize on early life exposure, how we can utilize that. And another point I want to mention about risk assessment or identifying high-risk population. If you want to do that, then few things are essential, like we want to have certain populations where disease have not developed, but you have all information about exposure, whether chemical, radiation, infectious agent, toxic substance, family history, diet, medication. And these biospecimens should be collected non-invasively. Then we need follow-up, like several times you have to take. What are the challenges or drawbacks in these kinds of experiments or study design? That these are expensive, and data sharing many times people don't do, but they should do. But advantages that these are essential if we want to identify, okay, these are the factors contributing to a disease, so that you can develop some therapeutic approaches. So in our program, we have samples from different populations, whether African American, Asian, Latin American, or Hawaiian. The reason is whenever a drug is developed, all people of different racial and ethnic group, they don't respond the same way. So we want to get involved with other populations also. So these are the countries from which we collect samples, we support them, and they store that. And we have 2.3 million subjects or their specimen, and those cohorts where disease have not developed, but we have access to those. Several of that our program supports, and some have been going on since early 70s, like nurses' health studies or physicians' health studies. So total 64 cohorts our program support, and membership should be that minimum 10,000 samples they should supply. And that way we get, those GWAS studies were done, and then the same sample or same people we are using in future to collect samples so that by epigenetics we can analyze. So time to time to promote this program, we write in different journals articles like early life exposure to infectious agents and later cancer development that I did before some time. And at NIH level, some money is congressionally mandated. They say that you have to spend on certain area. So this program, 1.5 years we initiated, it's called ECHO, or Environment and Influences on Child Health Outcome. There, before pregnancy, those mothers are enrolled, and some are already having small children or babies. So in that, about $165 million per year will be spent, and for 7 years it is committed. And then in this program, we have data analysis center, or that center which can do the actual analysis, or genetic core, or coordination center. So that's how it is done. And different life stages are there where samples will be collected, like preconceptual, anything prior to labor, perinatal, infancy, early childhood, middle childhood, adolescence. And this for 7 years that will be followed, and chances are that for next 7 years also it will be followed. So when early in life you get exposed, and which disease you develop, that will find out. And once you find out, then you can go back to those samples to see whether any molecular changes you can see which you can correlate with the disease. Epigenetics has been associated with behavior also, and some papers you will see like epigenome-wide association studies which correlate with aggressive behavior. Many things with genetics we could not understand, which with epigenetics we can do. This was for biopsychosocial pathways in epigenetic regulation. And many times we hear about health disparities, which is in social economic background. Those people who do not have good resources in those diseases were developing. So in that also what we are proposing, that epigenomic profiling they should do. So that kind of program also we are promoting. And in this, we have shown like genome-wide association studies you do. Similarly, those components like methylation profiling, histone profiling, or microRNA profiling, or chromatin compactation, or chromatin accessibility, that you do. But if you put these together, then you can get better results and better sensitivity to those biomarkers. And epigenetics also is affected by radiation, infectious agent, toxic substances, etc. And ultimately, that intermediate phenotype comes and disease develop. In this also, we face some challenges, but we have proposed also certain kind of solutions. For example, sample collection, what kind of sample should be there, what study design is there, what technology we have, whether high throughput is there or not. And I'm going to tell you also about the technology, how these epigenetics is done. And in environment, those agents which previously used to be for mutation only, now arsenic, benzene, cadmium, chromium, nickel, and all these have been found that they do epigenetic changes in different kind of cancers. So that way, more and more evidences are coming. And one paper came about cross-generational effect of alcohol dependence. In that also, methylation was the regulatory mechanism. The way toxicogenomics is there, by those agents some genomic changes are there. Now people are studying that before genomics, epigenomics also are changing. So those are called toxico-epigenomics changes. And this slide I put that whenever some abnormal thing happens, whether exposure or infection or other things, then first thing affected will be transcription factors or cell cycle regulators. In minutes to hours that can happen. If those exposures are for little longer, like 8 hours or one overnight, then methylation changes and epigenetic changes you can see. And here I have not shown, but in 24 hours or 2 days, you will see metabolomic changes. But it is for very long time, then only genetic changes come. That also emphasizes that if we can detect those changes early, then we can do something about the disease. And here we have shown like in different cancers, the way about genetic information we know. Similarly now about epigenetics, that information is coming. And in fact, certain genes have been identified which regulate methylation, but in that methylation, these mutations have been reported. So they are going in some cases both ways. Peter Jones and Andrew Feinberg. Peter Jones is at Michigan and Andrew Feinberg in Johns Hopkins. They were the pioneer who started thinking about epigenetic regulation, in which they saw that when active transcription is there, then histone is acetylated. At inactivation, it starts getting deacetylation, and at complete silencing, it gets methylated by DNA methylate transferase. And if you see chromatin at top, then chromatin is called relaxed or quite apart, and yellow color shows acetylation, But gradually this red color methylation starts, and many other transcription factors, other gene regulatory factors come, and these chromatin get so compact that transcription stops, and that's how epigenetic regulation works. And when methylation is also done, then one strand is methylated at one time, another at other time, and S-adenosine methionine that is converted to S-adenosyl homocysteine. So whenever you do such kind of experiments, both strands should be sequenced. At different stages of cancer development, these are the mutations, but in epigenetic changes, overall, initially, because of line and sign sequences, which cover about 90% of the genome, they are already methylated, their CpG sequence. So gradually with disease development or lifelong, global hypomethylation you will see, but for a specific gene, promoter gets hypermethylated. And histone modification, initially they are not there, but they increase in cancer. So this is one paper where they have measured that line 1 methylation status in prostate cancer, how it increases. So very systematically that was done to show line 1. These are also called jumping genes. So initially they just knew that they will go somewhere, but because of epigenetic regulation, this happens. Methylation also can happen in 3 ways, either abnormal increase or decrease or no change. In increase, like in tumor suppressor genes, either methylation of both alleles or one allele, and DNA imprinting of one gene and another is methylated. In abnormal decrease, it happens in proto-oncogenes or latent viral activation. If you remember in early 90s, when gene therapy just came, then retroviral vectors were used to introduce healthy gene into the other by recombinant technology. Since retroviruses were used so many times, they are promoted, which is called LTR. So those got hypermethylated and inactivated. That's why those vectors did not work, and recombinant DNA also did not work. But at that time, methylation and other things were not very well characterized. Now we know that. So now such vectors are created where that problem does not come. Wherever no change is there, then either chemically induced mutations or poor repair or deamination. So these are different combinations or possibilities which can arise due to DNA methylation. Here, after more research, different genes have been identified which are involved in epigenetic regulation, but some genetic changes have also been reported. Although this question comes whether genetics came first or epigenetics came first, but when whole epigenome roadmap initiative was started and in normal cells epigenetic profiling was done, then it was found that epigenetic changes came first. But now we want to know how they are correlated. Even in different network or pathway, different genes of pathway have been characterized in terms of what kind of epigenetic changes are there. Here I have shown integrin signaling. Now 10 years ago, we did not know about microRNA much. They were in Drosophila or plant, but then they were reported in animals or human. And now we know that even cancer-specific microRNAs are there. These are 20 to 25 nucleotide small RNA molecules, which are very stable and because of their secondary structure, and they can be used in epidemiology or epigenetics by 2 ways. Either you do microRNA profiling and you know which group of microRNA are increasing or decreasing. Based on that, you can tell whether some diseases or cancer is developing or not, or response to therapy, or those genes which are coding for microRNA. If there is any polymorphism, that also you can follow. MicroRNA, they either increase or decrease. So for in different diseases that people have followed. So for lung cancer, microRNAs will be different than liver cancer. And nowadays, another concept is also coming about exosomes. So somehow among all RNAs, microRNA are the one which gets concentrated in exosomes. So those from that can be collected, first of all, non-invasively, and microRNA from that can be characterized and can use for clinical purposes. So this is the one we wrote before some time, extracellular vesicles or exosome, and how we can utilize that. So a lot of research is going on, and those exosomes contain not only microRNA, sometimes DNA is also there, or protein or metabolites, so how they can be utilized. Regarding histone, as I mentioned, 4 kinds of subunits are there, and these are the tails of these histones which are modified, whether at lysine or other position, and those modifications are shown, which in different cancers those have been reported. When we initiated roadmap epigenomic program at NIH, then what we did, we gave contract to 2 companies to raise monoclonal antibodies against these modified moieties, so that can be used for screening purposes, and that was distributed to different investigators. And in those histone modifications, some will be for writing the instructions, some will be for removing. So all those also have been characterized, and along with histone, other proteins are also being characterized. And now technology exists, like it is called chip on chip. So by immunoprecipitation and other techniques, you can identify first by breaking chromatin and then precipitation that which chromatin or modifications are there, and at different times you can identify and sequence in which sequence which histone modifications are important. And cancer-related histone modifications, most of them are only 9 to 11. So if anybody starts any project for screening purposes or other purposes, then we recommend that those should be used. And here they are shown, like S3 protein at lysine 4 or lysine 9 or 27, where this is there and where they are acting, whether they are, how they are modified. So all those have been characterized. And these are used for diagnostic purposes also, histone modifications. And to combine and promote the field time to time, I have edited different books, either on cancer epigenetics or cancer epidemiology for host susceptibility factors or modifiable factors or cancer biomarkers, or this year was on progresses and challenges in precision medicine. As you know that every individual is different, so how we can utilize this information if a doctor follows a patient and takes samples again and again. I was interviewed one time by Nature to know why epigenetics is important compared to genetics. So then I emphasized that if you have mutation or certain changes in gene, you cannot go back, just you can use that to tell what disease will develop, what can happen. But these epigenetic changes, methylation and histone, you can reverse. So epigenetics has slight edge over genetics. And then next year again, I was interviewed by the same journal. Then by that time, certain drugs were introduced or identified, whether they were demethylating or histone modified. They can do histone modifications, so those were also identified. And different pharmaceutical companies, they started working on those drugs. We call those epigenetic inhibitors. In methylation projects, different kinds you have to keep in mind as to keep different kind of control to reduce false negative or false positive, like total methylation content or methylation level at a specific stage, or pattern or profile of methylation of either specific genes or a number of genes, or pattern in whole epigenome. But if all these controls are properly maintained, then methylation profiling will be very accurate. Steve Bellin, who is also in Johns Hopkins, he works on clinical epigenomics or translational epigenomics more. And they have characterized more non-histone proteins as well as different transcription factors and other factors and histone, their sequence when they combine and when they are released. And they do that kind of work. Suppose in H3 histone, K27 is trimethylated, then the gene will be involved in differentiation. Or if next amino acid, in this case S3K9 methylation is serine, then change will be permanent. So those kinds of basic research is also going on. Now at different stages of development of cancer, like progression, early detection, then diagnosis or therapeutic time, in these stages, different exfoliated cells come. So if these samples are collected, then many markers can be characterized from that. For different types of cancers, after doing investigators have done in different setup or institute, group of genes have been identified which in these cancers will be hypermethylated. Similarly, other kinds of proteins are there in which methylation changes or other changes are there. Those also have been characterized very well. Against those proteins or methylation changes, in different drugs are being developed. These are the ones for methylation changes in different trials or histone changes. In that, some of the promising results are also coming, although sometimes some adverse reaction like dehydration, diarrhea, nausea, vomiting, those you see. But still against HAT, histone acetyltransferase or DNMTs, against that, these are those drugs which are in pipeline. Whether it is Johnson & Johnson's or SmithKline Beecham or AstraZeneca, all of them have programs against these epigenetic drugs. If you get a chance to go to ASCO, American Society of Clinical Oncology, so latest results are presented there. And these inhibitors belong to different classes, short chain fatty acids or aliphatic compounds or cyclic tetrapeptides or benzamide. And same way histone deacetylases are also being characterized, like different forms are there. So against different forms also, those inhibitors are being developed. So these inhibitors provide a novel class of anti-cancer drugs, and sometimes they work as radiosensitizers, like regular treating agents. If you put, then many patients will not respond. But if you treat with epigenetic inhibitors first and then you use the regular drug, then it starts working. An example, one of this is there, where azacitidine for methylation drug or valproic acid histone drug that was used in those patients more than 50 where no other drug was working. So this combination was given, and by pyrosequencing, this methylation was done, and chip-on-chip analysis histone was done on day 1, 10, and 28, and they started responding. Similarly, in other example, combination of 5-azacitidine for demethylation, valproic acid, or trans-retinoic acid. For myeloid leukemia and myelodysplastic syndrome, that was used. Whenever that response with other drugs was not there, but then they observed that these drugs can improve the cancer development. And at NCI, we have several clinical trials are going on. Here I have shown for histone inhibitors, whether these are solid tumors or leukemia or lymphoma, breast cancer, or glioblastoma. These are different trials in which these epigenetic inhibitors are being tried. Similarly, for methylation inhibitors also on solid tumors or leukemia or myeloid leukemia or prostate cancer, these are being tried. And that I already mentioned, that Schering-Plough, Bristol-Myers, all these companies have many of these inhibitors in their pipeline. And the idea is the same, like these both inhibitors should be tried either alone or in combination, only epigenetic inhibitors or with other inhibitors, and several studies show those promising results. Gradually, FDA also found those studies useful, and 4 epigenetic inhibitors, so 2 for methylation, 2 for histones, those were approved by FDA. Later on, now we have altogether 1, 2, 3, 4, 5, 6. 6 inhibitors are there which are FDA approved. So it is not just like theoretically epigenetics we are understanding, but that is in clinic also. And Nature Reviews put something about clinical trials where epigenetic therapy is going on, so that you can search on your own if you are interested. And there you will find the information, what was the combination, which was given first, how much was the dose, what kind of background of patient was there. All those kinds of information is there. And time to time we also write about how they are doing in different kind of cancer in those studies which we support from our program. Like this is combination therapy of epigenetics for lung cancer. This one was for hematological epithelial tumor cells. So now I will tell different kind of cancers where epigenetics has been studied more. This is for colorectal cancer, in which methylation changes in whatever genes they are there, they are shown. Some are at very early stages, some are at later stages. But along with genetic changes and epigenetic changes, we follow microsatellite instability also. And in fact, in colon cancer, CpG Ireland methylator phenotype, or sometimes people called it SIMP phenotype that was observed. What happens that left side of colon behaves differently than right side of colon. With respect to EGFR receptor or BRFF mutation or this MSI microsatellite instability high or low or methylation pattern, these sites are different and they respond also differently to different inhibitors. So in that, only by epigenetic characterization it was found that colon cancer should be treated differently. Now another area is also coming of microbiome, where microbes or microbiota, they make their colonies in colon and they make biofilm. So we want to integrate that data with this and see whether that can improve our treatment or not. But just by methylation profiling, when that was done, then KRAS mutation or BRF mutation or MSI high or this methylation, they came in a group. And we could identify a group of genes which they are used along with MSI. They can tell who is at high risk of developing colorectal cancer. So it is not like screening only you have to do, but other some non-invasive technology also you can do for detecting colorectal cancer. In AML and ALL, acute myeloid leukemia or lymphoblastic, based on methylation patterns, healthy people could be distinguished from ALL or AML. In case of lung cancer, along with proteomic marker, these epigenetic markers were used, and even in sputum you can do that test, and Steve Belinsky has done this kind of work. Asbestos exposure in mesothelioma. Just by methylation profiling, those two groups can be identified, and these have been done a large number of people. In esophageal cancer, Barrett is the early stage. So methylation pattern in 20 genes or so, if you follow, that some genes are methylated at early stages, some are at later stages. So longitudinally, if you follow the same patient, you can tell that that person is at high risk of developing this cancer. And that methylation profiling can be correlated to survival also after treatment, whether patient is surviving or not. Many times people ask that for cohort or clinical trials, why we collect information regarding patient's history, exposure history, or others. But it is very important because if somebody is alcoholic, they have KRAS mutation, long-standing diabetes. And for pancreatic cancer, currently we don't have early detection markers, but along with those features, if P16 and P14, they get hypermethylated, then it means those people are at high risk of developing pancreatic cancer. Otherwise, pancreatic cancer and ovarian cancer are such that in 1 or 2 years, by the time it is detected, it is too late. For breast cancer, lung cancer, colon cancer, and some other cancers, it takes 15-20 years, but these are such very fatal cancers. In breast cancer, treatment can also be followed by based on methylation profiling. Now comes those infectious agents. Many infectious agents like HPV, SV40, HCV, EBV pylori, they have been associated with many other cancers. In fact, if we see all cancers, then in 15% of total cancers, infectious agents are involved. And in that, latency-associated nuclear antigen or Epstein-Barr virus nuclear antigen, they are the main genes which are involved. Recently, for papillomavirus, which is for cervical cancer, or EBV for nasopharyngeal carcinoma, or for liver cancer, whole methylation profiling has been done. Why we are interested in these kinds of research? That just by pathological examination or histology, you cannot tell that a person will develop those cancers or not. But if we know this profiling, then we know that the person is at high risk. So here, like in HPV, early genes or E6, E7 or late genes are there. Whatever genes, when it is methylated and what was the extent of methylation at different stages, those have been characterized completely. And to promote this area, we have put on HIV, AIDS, or other viral methylation also. That area we are promoting. Or for liver cancer, in that hepatitis B or C, those are being characterized. And in hepatocellular carcinoma, as you know, mostly in Asian and Japanese population is there. So one gene was observed where hypermethylation was observed only in Japanese population. So sometimes some changes are very much population based, some are very common, like for hepatocellular carcinoma. This group of genes generally gets hypermethylated. In immune system also, T cell or B cell during their development or doing their different functions, epigenetics has been characterized very well. And T cell methyltransferase in cancer and other disease, those have also been characterized. Now in prostate cancer, mostly PSA is the one which was used or is still being used, but when level is less than 4 nanogram per ml, then clinician does not know whether they should wait or they should treat, because prostate cancer as such, it takes long time, so whether go for surgery or chemotherapy or radiation. But then GST-P1 methylation came in such a way that in most of the cases, those hypermethylated groups, they indicate better results. And then comparison with prostate cancer was also done. Then Epigenomics, one company was there which developed this test, and they worked with Quest Diagnostics. And now that Quest Diagnostic, they do for prostate cancer that test also, and they have different prices. In bladder cancer, exfoliated cells which come in urine, if you collect that, those have sufficient amount of DNA which you can use for methylation profiling. So bladder cancer, like lung cancer and bladder cancer with smoke or tobacco, they are affected, so that you can use. Now that also happens with methylation profiling, like Peter Laird in University of Southern California. With that, many times what happens that cancer, at one stage it is in one organ site, in another stage it is on other site, or sometimes secondary cancer also comes. So he uses the pattern and can identify which other cancers a person is likely to develop, or prediction models they develop based on that. Now comes a little bit about prevention. As I mentioned that epigenetic changes, those you can reverse. So in that, it is our understanding that cancers, since most of the time, environment and lifestyle and diet and exposure, they play a major role. So if you change that, then you can prevent cancer. In fact, 30 to 40% cancers are preventable. So that kind of research was done, and in liver cancer, one model was developed where no carcinogen was added, just methyl donor was supplied, and such kind of situation was developed. It was very similar to liver cancer. And then in different food and their biological components, those were characterized. For example, in turmeric, cinnamon, or apple, or citrus, or coffee, broccoli, garlic, etc. So some food have demethylating properties. Some have only histone modification, antihistone modification properties. Some have both. So we have Institute of Alternative Medicine where they are trying to utilize that natural food, how they can do and how much epigenetic mechanism is going on. I also wrote one article on nutrition and epigenetics to cover that area. Now comes what NIH has done to promote this area. When Dr. Zahruni was director of NIH, that time he initiated one program that about 1.2 to 1.5% of budget, if all institutes contribute, then that can be utilized to understand such biology which individual institute cannot support, but it will be very helpful. So in first round, microbiome and epigenetics, these two programs was promoted because epigenetics, that in several disorders that was observed. But it was not known the way we have in genome. From healthy people also we have sequence. In proteomics we have proteomic profiling. But for methylation profiling and histone and microRNA and others we did not have. So this epigenomic roadmap program was initiated. Idea was of that roadmap program that for 5 to 10 major projects can be started which are of high risk, but for that they can contribute a lot in translation or transformative biology. So after that, other directors came and Francis Collins came, so he changed its name to Common Fund. And as an example, you can see that in 2015 and 16 also almost the same amount, about $500 million were spent. And I have been involved in 3 major programs from the start: Epigenomics Roadmap Program, and then metabolomics, and then this molecular transducers of physical activities. So in that, we are doing such research which is for healthy people, what kind of profiling is there, or increasing the capacity to do that kind of analysis. So that is done, and these are other programs which are going on, like single cell analysis is there, or global health, science and behavior, genomic tumor expression, etc. So for epigenomic roadmap, you can imagine, and these are all congressionally mandated programs. So first money will go to this program, then only it will be distributed to others. So in 2008, we started, and we did it that for mapping of different sites for epigenetics. And let me show you this slide. And Nature covered 2 years ago whole epigenomic roadmap, what kind of data we got. So since for different organs, different tissues have different epigenomic profiling, so about 112 kind of cells were characterized from brain, breast, liver, duodenum. So these are the sites from which cells were collected. Protocols or assay standards were developed, and then complete epigenomic database was created. And complete means like methylation profiling, histone profiling, microRNA, and DNA is one mapping. So these are the types of cells shown here which were taken, and some from stem cells also. So now we have some reference point so that we can use that if someone develops a disease, that what kind of changes are in healthy people, what kind are in the diseased person. And through that, several high quality papers were also published during that time. On parallel, internationally also several efforts were conducted, and one of the example is International Human Epigenome Consortium, or IHEC. This in Europe it was developed, and we participate in that so that there is no overlap. They want to do in model organism also, and other disease also they want to develop, and their idea was that about 1,000 epigenome they will be doing. So when we had our first meeting, that time these are the countries who participated in that. And then funding agencies were also different. Like we are funding epigenome roadmap, but other people came. And industries, they supplied mostly equipment and other resources, and Nature and Science covered that. And every year IHEC has annual meeting where we update each other. And AACR, American Association of Cancer Research, they also cover that. This is IHEC website, so they keep track of whatever is happening in Europe, Asia, and other places. We keep track of US, but we exchange our views and conference calls at least twice in a year. Now, other challenges which are coming to bring it to clinic, how at NIH or NCI we are doing. So we usually write articles in which we write, these are the future research program where people should do research. So this we did on epidemiology, what are the trends and challenges, or molecular profiling, how we can use that for personalized medicine or precision medicine. And then Obama initiated this program. This was called Precision Medicine Initiative. So in that idea was that about 1 million people will be enrolled, and their electronic records will be maintained for them from the start and whenever treatment is there and when they are undergoing some kind of analysis, and their data will be available to all. So this was initiated, and then recently its name was changed, just all of us, but program is the same. But this is also done by congressionally mandated program. Since those kinds of information are coming, like one drug or one assay will not work for all. And more and more, whenever you go to a doctor, they record electronically your information, and whatever is not recorded, that also we ask them to put that for future. So in these will be very useful in future. Although as it happens, here also we have bioinformatics challenges or recruitment and others, but we think that we are in right direction. Then came 21st Century Cure Act, in which Moonshot program came from NCI, and NHGRI, that Genome Research Institute, also participated. In this program, these two institutes were giving additional money, about $350 million, and this is also for many years. Here, idea was that whatever research is going on in translational, epigenetics, or other kind of program, then how they can make the speed faster, how you can bring that quicker to the clinic. So that has been going on. Now we have written those programs which are called funding opportunity announcement, or RFAs, and then people are going to submit their projects. And by mid-year next year, FY18, we are going to fund this program. And to promote that personalized medicine, other articles also we write, or in cancer epidemiology, because this is the way to identify different kinds of risk factors or causative agent. We promote that epidemiology a lot by writing these kinds of articles, or stem cells, how we can utilize that. So what are the current research opportunities and challenges based on what I gave you background? Whether these epigenetic markers or these profiling, they can help us in identifying new risk factors, or can establish that what factors we have, those are good for different races and ethnic group. Then whether case control studies or cohort studies, or which study design we should follow to do that kind of research. How much correlation is there in genetics and epigenetics, and whether racial or ethnic specific microRNA or long non-coding RNA we can identify, or how we can use these kinds of information for different subcategories or subtyping of cancers. As you know, in breast cancer, as such it is one breast cancer, but 11 kinds of cells are in even breast cancer. So that molecular subtyping many times, for those pathologists who are trained earlier, it is very difficult for them to distinguish. And they respond to treatment differently, but by molecular characterization that can be done. These are my collaborators, and I want to leave with this quote that our genome and its superimposed epigenome code, this is a journey we have embarked on, one that is paved the roadblocks, but also with many amazing discoveries and success stories, both in cancer medicine and cancer science. We are privileged to be part of those and to share them with all of you. Thank you. I will take any questions or clarification, or I did not cover well.
So what do you think is the best target, the methylation or the histone assimilation?
In different cancers, they are giving different results. Sometimes histone and sometimes methylation. But best results so far in clinical trials are coming from those where regular agents, they are not that much effective, but if you pre-treat with histone and then after some time introduce methylation inhibitors also, then they give good results. So it is a matter of which we should start first, which second, and how much dose we should use. But many more are coming, and also, especially in histone deacetylase, different forms have been identified. So pharmaceutical companies for different forms, they are creating those inhibitors. But they are coming very well, and now we have at least 6 such established. They are being used. And one thing, as you know, that with time or with age, we collect so much somatic mutations and SNPs and all those. Some come with age, some come with disease, but we cannot go back. But if we can identify these, then probably since they are reversing, then it does good. But still, best way is that people change lifestyle and then use those natural food and other things, then you can prevent and do that, because they have inherent epigenetic inhibiting properties, many of those foods.
So do you think that the epigenetic phenomena is more important in the young relative to the old?
Yes, that is very well. That at least has come out, and that's the reason that 1.5 years ago that ECHO program was initiated, Environment Influences on Health, Child Health Outcome. The reason was, and also to do that, what was the condition? That those centers which want to do that research, they should have ongoing studies, and they are enrolling pregnant mothers, or they have that. So 84 cohorts were identified, so and 34 investigators we funded. So they are doing their own research. But we have come out with one common protocol and common collection of material like nail, hair, and psychosocial stress, income, education, all those data is being collected. And whenever they go to clinic, whatever biospecimen they can do and molecular analysis can be done, that is being done. And those will be followed for a long time. Otherwise, in disease diagnosis and prognosis, what was happening? That when you are very sick, then doctor is seeing you, and then based on that, they are prescribing. But they did not know when it started, whether we can stop that early. So on early exposure, emphasis is very much. So with NIEHS, National Institute of Environmental Health Sciences, and we work together, or at NIH level also.
Okay, well, thank you. I think we'll be moving
Thanks.
on. And we have some announcements. And our last class for this year will be next Monday, December 4th. And we'll be having lectures on pancreatic cancer and nanotechnology. And unfortunately, I'll be out of town then. So Dr. Zia, who gave the breast cancer lecture, she'll be here distributing the handouts and introducing the speakers. And then when the class is over, it's possible to get a certificate of completion of the course. And so what we'll be doing is by December 11, we'll be posting the final exam. And it's a multiple guess exam graded by the computer. It's got one question from each of the lectures. And if you get 70% of the answers correct, then you pass. And the exam will be online for about a month. And then hopefully at the end of January, we'll be printing the certificates. Usually about 40 to 50 people from TRACO actually complete the course and get the certificate. So if you have any questions on that, contact me. And our last lecture today is by Dr. Olako of the Division of Cancer Treatment and Diagnosis. And for TRACO, many of you visited the tumor boards and heard about case reports. And today, Dr. Olako presents the case reports to you.
Thank you.
Welcome.
Thank you, and thank you for staying behind. I really appreciate it. I'm going to talk about case reports. So the objectives, what I hope to achieve during this lecture is to describe the history of case reports, recognize the potential roles of case reports, describe case reports, outline pertinent information for a good case report. Case report is defined, at least one definition is a formal summary of a unique patient and his or her illness, including the presenting signs and symptoms, diagnostic studies, treatment course, and outcome. Case reports probably started, the oldest example of probably the preserved medical literature containing clinical cases from Egyptian antiquity papyrus. And that was thought to be around 1600 BC. Some people think that they were probably rewritten texts from some centuries before that time. Among these were 48 cases discussing injuries or disorders of the head and upper torso. Case reports are usually described using the centuries in which they were written or by the main actors or people that were involved in the writing of the case reports. So for example, we have what's called the Hippocratic case reports. And this emphasize accurate descriptions of only clinically relevant findings. And both the physical and mental findings were described, and the patient's version of her complaints was for the most part absent. Then you have what we call the Galenic case reports. This introduced a more conversational tone into the case reports, and Galen often described his working day, his doubts, his tentative diagnosis, and his interactions with other physicians as the disease unfolds. Some people believe that in the Middle Ages, medicine in the Western world was dormant. However, there was increased a lot of information coming out from the Islamic medicine. And those case reports were similar to both the Hippocratic and the Galenic case reports. And most of those case reports adhere to the Galenic ideas of having a conversational tone, but they also put more emphasis on patients' subjective experiences. At the same time, physicians were dramatic in the way they wrote case reports. And for example, in a case report that appeared in the Philosophical Transactions in 1739 had a title saying a girl 3 years old who remained a quarter of an hour underwater without drowning. In the 19th century, case reports dealt less with patient subjective accounts of their illnesses, and more technical terms were introduced into the case reports. They were more organized and having sections like demographic details of the patient and outline of clinical course of events. At the same time, medical terminology became more prominent. Similarly, looking at cancer patients, the history was pretty much the same, and Milo Janicek eloquently describes case reports as the first line of evidence where everything begins. Some of the earliest case reports of incurable breast tumors were also recorded in the ancient Egyptian, the papyrus records of the ancient Egyptian medicine. So what are the potential roles of case reports and case series? One is recognition and description of new disease. In 1999, the West Nile encephalitis was identified in New York City as a new case in the United States. Another possible role is detection of drug side effects. Most drug retractions usually follow case reports. On the other hand, there are also advantages or beneficial things that can come out of case reports. For example, sildenafil was designed as a drug to treat hypertension. However, in the course of the trial, they found out that a beneficial side effect was picked up, which is now benefiting a lot of people. Sildenafil is the trade name is Viagra, but it was discovered accidentally. In the same vein, you have antidepressant drugs that were found to be useful for patients who are undergoing smoking cessation, because they were found a link between smoking cessation and depression. And so antidepressant drugs were prescribed for those patients. Case reports also can be useful in the study of mechanism of disease. For example, maternally inherited diabetes associated with deafness. This was discovered by looking at family history of people and was able to identify this disease, and then from there onwards, they were able to identify the mechanism. Case reports can be very useful in medical education and audit. It's also useful in the recognition of rare manifestation of diseases, and it can also have impact on health policy. For example, recently the Zika virus, or a few years ago with the Ebola virus, where policies had to be made as a result of the cases that came into the United States. So case reports can be used in describing new disease or diagnosis. Historically, case reports started as communication between physicians, and that ultimately became the origin of journals. Hippocrates and Rufus of Ephesus described case reports of melanoma, and in January of 1832, Thomas Hodgkin described 6 cases, 2 of which we now know as Hodgkin's disease. Similarly, in 1957, Dennis Bucket described tumor in the jaw, the angle of the jaw of the African children, that is also called Bucket's lymphoma today. And in 1990, Fassett and colleagues described 2 patients with a new type of lymphoma called hepatosplenic T-cell lymphoma that has led to more focused research. So we're going to describe some case reports to you. This is a case of a young female athlete with acute low back pain caused by stage 4 breast cancer. This is a 27-year-old lady that presented to the office of the chiropractor with the chief complaint of lower back pain after warming up and participating in kickball match. She reported feeling some discomfort while jogging and subsequently having pain after striking the ball with her right foot. The pain was mainly on the L2, L3 level with mild radiation around the right paravertebral region. On a scale of 1 to 10, she described this pain as constant, sharp, and stabbing, 8 out of 10, but there was no radiation of the pain into the extremities. She had a past history of uncomplicated low back pain during her teenage years that was treated conservatively and was attributed to lumbar scoliosis. On physical examination, there was decrease in flexion and extension, active range of motion with pain in the upper lumbar area, and there was +4 tenderness on palpation. The patella and Achilles tendon reflexes were 2 out of 4, and the Babinski and lower extremity clonus were absent bilaterally. The muscle testing was similar on both sides, and around the paraspinal muscle, there was increased tone at the level of the complaint. However, there was a positive family history of breast cancer in the patient's aunt and grandmother. And in previous years, she had routine mammograms to observe a cyst in her right breast. At the time of presentation, she had not had that screening for that particular year yet. So a diagnosis of lumbar sprain and strain was made, and radiographs obtained to rule out spondylolysis did not reveal any signs of fracture of dislocation. However, after the diagnosis, when they look back retrospectively, they found out that there were subtle lucencies that were visible on the vertebral body and the left pedicle that they had missed initially. And you can see on the arrow, you need the eye of faith to see it is slightly lucent here and around the pedicle, same thing here. So they treated her with soft tissue mobilizations to her lumbar and hip, and she was placed on conservative treatment plan for 2 weeks. At the same time, her employer's physician prescribed oral anti-inflammatory drugs and physical therapy, which she had to strengthen the core musculature and increase the range of motion. 2 weeks after she returned to her chiropractic office, because the signs and symptoms did not change, and an MRI scan revealed a 2.2 centimeters expansible lesion in the left L2 vertebral body with associated overlying vertebral superior end plate concavity focally. And there were differential diagnoses of different things: osteoblastoma, giant cell tumor, pathologic fracture, metastatic disease of unknown origin was made. And so you can see here and here, the tumor, you can see here spreading to the pedicle. So she was, at that time, she was referred to an oncologist who made diagnosis of stage 4 disease, breast cancer. She had an ultrasound and mammogram guided biopsy that revealed a cancerous tumor in the right breast. 2 more metastatic lesions were discovered at the C6, C7 spinal levels via bone scan and MRI. The tumor was hormone receptor positive and HER2 negative. Interestingly, the original cyst was found to be benign. So the tumor was below the original cyst they were monitoring over the years. She was treated with letrozole, Ibrance, and Falsodex, and she had a right lumpectomy and axillary lymph node removal in 2016. The spinal lesions diminished. However, there was a metastatic lesion that was confined to the liver. However, this year, she began the trial of Xeloda, and she's currently active in exercise, participating in weight training and bowling. This is a case of a lady who has squamous cell carcinoma of the tongue during pregnancy. The 29-year-old lady in her third pregnancy with 2 children. She was referred at 14 weeks gestation to the oral and maxillofacial surgery service with biopsy proving poorly differentiated squamous cell carcinoma with perineural invasion of the right tongue in the area of erythroleukoplakia. She don't have any history of smoking, and she consumed alcohol occasionally before her pregnancy. So that's the area that was biopsy, the lesion that found that she had carcinoma of the tongue. MRI imaging depicted an endophytic mass of the right tongue approaching the midline, and the genioglossus muscle on the right-hand side was involved with prominent ipsilateral level 2A lymph node was noted. So the clinical and radiological diagnosis, she was diagnosed as stage T4A N1 MX. So, and that's the MRI. So you can see the tumor there. They discussed the management options. The patient wanted to continue her pregnancy, and at 16 weeks gestation, she underwent a right hemiglossectomy and bilateral level 1 to 4 neck dissection, radial forearm free flap reconstruction, and a tracheostomy. So you can see this was the excised part of the tongue, and this is what it looks like after they repaired using the flap. So she had a neck dissection on the opposite side because the malignancy was encroaching the midline of the tongue. She had infection that was treated post-operatively, and pathology report revealed that the margins of the mass was negative for carcinoma. However, 2 lymph nodes were found to be positive for regional metastasis with extracapsular spread at the same side of the tumor level 4 and on the other side level 1. And so they had to change the staging of the disease. This is histology that shows you the breaking of the capsula and the tumor from the lymph node. So after discussion with the maternal and the fetal risk, she had adjuvant chemoradiotherapy on post-operative day 25. She had 60 gray to the operative bed and 66 gray to the sites of regional metastasis. And she had weekly carboplatin. She had adjuvant therapy was completed 26 weeks of gestation, and the estimated fetal dose was 7 centigrade of radiation. She had serial ultrasound scan performed to evaluate the fetal growth. And this is just a picture of the lady showing how she was treated with radiation. The ultrasound depicted appropriately grown fetus measuring at the 92nd percentile at 23 weeks gestation, but dropped down to the 36th percentile at 31 and 37 weeks. She had a live-born male infant delivered vaginally at 39 weeks, 3.118 grams. 1 year after, mother and child are doing well with no evidence of recurrence. So this just shows the growth over the period of the pregnancy. This is another case of an 18-month-old girl. It's a yolk sac tumor of the abdominal wall of an 18-month-old girl. She had a small, round subcutaneous lump, 1.5 by 1.3 by 0.8 centimeters of the abdominal wall in a right hypochondriac region. The tumor was connected to her skin, and histology confirmed the yolk sac tumor, showing a microcystic reticular pattern with positive staining for cytokeratin 8, as well as cytoplasmic granular staining for alpha-fetoprotein. So that shows you the histology and the staining for alpha-fetoprotein. During surgery, the borders were not clear of tissue, and she was staged as stage 2 according to pediatric oncology group. The alpha-fetoprotein was 57 normal, usually less than 10 nanograms per mil, 3 weeks after resection, and dropped to 50 nanograms per mil 1 month later. The beta subunit of the human coronary gonadotrophic was normal. MRI of the abdomen was normal. She was followed up with serial alpha-fetoprotein. 1 year later, she had a recurrence, 1.1 centimeters, and the alpha-fetoprotein level was 29 nanograms per mil. MRI of the head, neck, thorax, abdomen did not show any masses. At this time, they had a wide excision of the lesion that confirmed diagnosis by pathology. So that's the lesion there. You can see they measured it, and here on MRI. So this just gives a graphical representation of the measuring of the alpha-fetoprotein before it came back to normal. So 5 years, she's fine, tumor-free, without any remission. This is a case of nivolumab-induced hypothyroidism and selective pituitary insufficiency in a patient with lung adenocarcinoma. As a 60-year-old male patient that presented with a soft tissue edema in the right cervical region in 2014. He had a history of 86 pack years, and he was a social alcohol consumer. CT scan identified a 2.6 centimeter mass in the right upper lobe of the lung, along with abnormally enlarged mediastinal lymph nodes without further evidence of distant metastasis. Biopsy was confirmed by bronchoscopy, was staged as 3A, and patient had concurrent chemoradiotherapy with cisplatin and 54 gray of radiation. That resulted in partial response according to the RECIST criteria. And surveillance CT in May 2016 showed progressive disease with enlargement of tumor and mediastinal lymphadenopathy with a new supraclavicular and cervical lymph node block. So they started a second line of chemotherapy that included intravenous nivolumab. Following the 11th cycle, patient developed symptoms of dizziness, gait instability, fatigue, anorexia, withdrawal, periodic confusion, and reduced alertness. Physical examination disclosed ankle edema and bradycardia and no focal neurological or other organ signs. CT ruled out central nervous system metastasis. As a result of the worsening symptoms, they had to request for a thyroid function test that showed that the TSH level was pretty high, and the free T4, T3 levels were low. So a diagnosis of hypothyroidism was made that was probably due to the nivolumab. So they prescribed to her levothyroxine sodium and liothyronine, and they discontinued the nivolumab. Despite all the treatment of thyroxine, patient continued to experience fatigue, loss of appetite, joint stiffness, nausea, and periodic abdominal pain. On examination, patient was found to be hypotensive, dehydrated, and had skin exfoliative dermatitis. All those symptoms were compatible with adrenocortical insufficiency with further hormonal information confirming that. The ACTH level was low, 1.4. All other biochemical and hematological serum examinations were normal. MRI, brain MRI was normal. And there was no metastasis or involvement of the pituitary gland, but not the hypophysis. So this is the MRI of the brain that was normal. So the results confirm a clinically suspected adrenal insufficiency that was most likely selective and was induced by the anti-PD-1 blockade. The LH, FSH levels, testosterone were all normal, and he was commenced on oral hydrocortisone in addition to the thyroxine medication he was taking. Therapy resulted in a gradual resolution of all symptoms and signs related to hypothyroidism and adrenal failure. An examination in March 2017. The patient was alert, afebrile with normal blood pressure, good appetite, and disappearance of skin exfoliation. And the blood levels were within normal range. A CT scan of head and neck and abdomen, upper abdomen performed in April of this year revealed stable disease in the neck, lung, and mediastinum. So this just shows you the differences in the skin lesions before and after treatment. And this just gives you a graphical representation of the hormone levels as they went up and down following treatment. And it's just a table showing you the clinical and laboratory evolution over time. So now look at rare cases. In rare cases, it's very difficult to do clinical studies, and the only evidence, quote unquote, that the clinician will have might be case series, which will inform rational approach to treating the particular disease. This is a case of a 15-year-old girl, a rare case of biventricular myxoma that was admitted with symptoms of cardiorespiratory distress and anasarca. She complained of symptoms of congestive heart failure for 20 days. Clinical examination showed blood pressure to be normal, temperature normal. She was high. The breath sound, she was breathing 24 breaths per minute. She had facial edema. She was pale. On chest auscultation, the breath sounds in the both lungs had evidence of fluid in the lungs. And there was precordial tremble and strong apex beat was noted on palpation with a massive murmur starting in systole and extending to the end of diastole. Other findings include an enlarged liver, positive jugular vein reflux, and edema of the lower limbs. The albumin levels lower than normal. The N-terminal fragment of brain natriuretic peptide was high. CA125 was high. Chest X-ray revealed some cardiac dilatation with right lower pneumonia and pleural effusion. Echocardiogram revealed multiple cardiac masses. A large right ventricular mass, 5 centimeters by 4 centimeters, arising from the right ventricle apex and prolapsing through the tricuspid valve into the right atrium during systole. So that's the ultrasound scan showing you the mass. Again, the multiple masses on ultrasound scan. The left ventricle was not dilated and showed normal ejection fraction, had mild pericardial effusion. The findings were highly suggestive of myxomas, although diagnosis of vegetation or thrombus could not be excluded. CT scan revealed multiple low-density, well-delineated shadows. Size of the largest mass, 5.5 by 3.8 centimeters. Again, you can see the CT scan. PET scan also revealed the tumor. And in fluorodeoxyglucose test revealed an enhancement pattern suggestive of a benign lesion and likely a mucous tumor. No obvious malignant lesion was identified during the workup. So you can see the PET scan, all this lighting up, showing the tumor. So she had surgery. A massive red thrombus was seen clearly in the auricular dextra pectinate muscles of the right atrium and postcava opening near the right atrium. A 60 by 45 millimeter red tumor was found in the right ventricle after removal of the thrombus. It had prolapsed into the right atrium through the tricuspid valve, as was seen on ultrasound scan. So that's the tumor there. That's the heart of the tumor inside. Pathological examination confirmed they had diagnosis of multiple cardiac myxomas, and during 10-month follow-up, patient was asymptomatic and had normal blood pressure. There were no signs of recurrence or valvular insufficiency. So that's what was removed. That's just the histology. This is a case of a 90-year-old man, lung cancer with melena, this blood in the stools. The 90-year-old man had a history of a left upper lobe pulmonary nodule on prior imaging, presented with dark tarry stools, fatigue, and repeated falls that progressively became worse over a month period. He had a past history of smoking. At the time, the last time they scoped was about 10 years prior to presentation. 5 months before, a 2.4 centimeter left upper lobe pulmonary nodule suspicious of neoplasm was incidentally found on chest X-ray. Patient declined any invasive procedures. 2 months after, new scattered 8 millimeter hepatic nodules suspicious for metastatic lesions were found on a CT scan of the abdomen and pelvis. PET scan confirmed the same thing. So that's what this is showing. It's the nodules on the liver. That's the lung mass, and that's on lighting up there. CT of the head negative for metastasis. Clinically, it was stage 4 primary lung neoplasm. All those things were positive. Fecal local blood test was positive. He had a low hemoglobin, low hematocrit. And the scoping, when they did an endoscopy, he had a non-obstructing, non-bleeding cratered gastric ulcer at the greater curvature of the gastric body. They also had a clean base, no stigmata of bleeding, and no evidence of perforation. Biopsy confirmed metastatic squamous carcinoma involving the base of the gastric mucosa without surface involvement. He was referred to palliative care, and unfortunately, 54 days after he passed away from GI bleed. So that's the histology. This is a very, again, another variety of case giving you interesting. This is a 64-year-old male patient that was admitted to hospital with progressive dyspnea and cough. He had undergone a right lobectomy for liver cancer in October 2006. 14 months after, a chest CT scan revealed multiple metastases and left adrenal gland metastasis. Investigation showed that had liver cancer. Patient was placed on palliative chemotherapy with 5-FU, adriamycin, carboplatin. Disease progressed following 2 cycles of chemotherapy. They introduced second-line treatment and third-line chemotherapy of those drugs listed. There was no response, and patient was referred to a palliative care facility in February of 2009. He had a past history of hepatitis B virus infection. It's just the blood investigation results. This is high, just, So anyway, shows the chest radiograph revealed miliary nodules in the lungs. So that's the chest radiograph showing all the nodules, CT scan, all over. So he was seen every 3 months in palliative care. He continued to have cough and dyspnea, no changes on the chest radiograph. However, on the second visit in September 2009, the general condition of the patient improved and the cough and dyspnea had stopped. And the chest radiograph revealed that all metastatic nodules had disappeared. So this is clear. Alpha-fetoprotein had dropped. Whole body PET scan in December 2009 revealed that all metastatic nodules in the lung, as well as the metastatic lesions of the 2 adrenal glands and lymph nodes, had disappeared. Patient said he had taken some herbal medicine, Dendropanax mobifera, for approximately 1 week on recommendation of his family, and follow-up CT scan did not reveal any recurrent disease. And as at May of 2013, patient was alive without any symptoms. This just gives you an idea of showing the scan, chest X-ray while the nodules were there, and then when it cleared up to the time the case report was published. this is a de novo hepatocellular carcinoma post-multivisceral transplantation in a child. This is a child that was born 32 weeks prematurely because had gastroschisis, which is the anterior abdominal wall is missing, so the organs are protruding out of the abdomen. Because of that exposure, the gut became had necrosis, so they had to remove the gut. So in order to feed the patient, she had to have total parenteral nutrition. As a result of that, she developed cholestatic liver disease that progressed to cirrhosis, severe portal hypertension, and subsequent decompensation with coagulopathy. At 8 months of age, she had a transplant, liver, small bowel, pancreas, and spleen transplantation. The deceased donor was a 3-year-old that was previously healthy female with no prior relevant medical history, and the cause of death was head trauma. The donor was negative for hepatitis A, B, and C, however, was positive for Epstein-Barr virus, IgG. HLA cross-match was negative. Surgery was complicated by compartment syndrome, abdominal compartment syndrome requiring splenectomy. Patient received drugs to had received immunosuppressive therapy, tacrolimus and prednisolone. 2 months after the transplant, developed EBV viremia that was reduced by immunosuppression and ganciclovir. There was rejection. Again, they increased the immunosuppression therapy. And the EBV viremia recurred at 3 months, and she developed post-transplant lymphoproliferative disease, which was confirmed histologically by a biopsy of inguinal and axillary lymph nodes. Condition improved after dose of tacrolimus was reduced and rituximab was administered. She had intestinal graft dysfunction that led to 8 ileoscopies and biopsies over a period of 4 months. At 3 years of age, she was found to have a multifocal post-transplant EBV-associated smooth muscles tumor in the small bowel and mesentery confirmed by biopsies. The tumors are not responsive to chemotherapy, radio, or surgical resection. She was enrolled in a clinical trial at Memorial Sloan Kettering in New York and received several cycles of genetically modified EBV-specific cytotoxic T lymphocytes in addition to vorinostat as part of a research protocol. She was clinically stable. However, the EBV-associated tumor was progressive. She remained at home without any need for frequent hospitalizations for 4 years. 6 years after transplantation, routine scans showed that there was a tumor, a hypervascular mass in the patient's liver. MRI identified a heterogeneous left dominant hepatic tumor with multiple hypervascular foci unchanged from the prior CT. Clinically, the patient was well and stable. However, the liver lesion increased in size. Biopsy confirmed hepatocellular carcinoma, clear cell variant, and the patient underwent a left hepatic lobectomy with clear resection margins. However, there were some residual liver tan yellow nodules ranging from 0.3 by 0.3 to 1.5 by 0.9 by 0.6 centimeters. So that's the resected tumor there and some of the histology and staining that was done. Uneventful course postoperatively, discharged 11 days after, stable for 7 months, and then MRI revealed that there were multiple nodules in the liver, and alpha-fetoprotein level had gone up. Findings consistent with recurrent disease. Patient's family decided to proceed with comfort care. Unfortunately, the patient passed away 6 months after. So our case reports are important in this era of evidence-based medicine. Some people believe that case reports should be eliminated. That doesn't contribute much to science or to evidence. However, Case reports cannot provide evidence of any efficacy or safety in diagnosis and treatment of a disorder. Albright and his colleagues studied 100 published case reports in the archives of dermatology. They had concerns which included publication bias in support of positive results, exaggerated claims of efficacy and safety, inadequate informed consent reporting, underreporting of patient-centered outcomes. Another challenge for case reports is that from a business perspective, case reports are rarely cited, and as a result of that, they generally negatively have a negative impact on the impact factor, a negative effect on the impact factor. And that may be something that is important for corporations or pharma that are trying to advertise, or people who want to publish will probably want to publish in a journal that has a high impact factor, which will drive where people who are advertising will spend their dollars to advertise. We know that evidence-based medicine is concerned with finding the best evidence for clinical decisions. For example, what we apply to a particular therapy or diagnostic test to a particular patient. Randomized clinical trial serves a very good purpose, the final evaluation of therapies or tests, especially when their clinical value is not immediately clear-cut. However, case reports have other aims that are equally important in the progress of medical science and education. So we look at meta-analysis of systemic reviews of case reports and case series. Mayfield and Gorin retrieved from the literature 21 cases of tamoxifen-related ocular toxicity in breast cancer patients. As a result of that, they had a clearer picture of the nature and distribution of the toxicity as well as the severity of the ocular findings. However, they also recognized that it was difficult to attribute the ocular findings to tamoxifen and other competing causes of retinal, macular, or corneal abnormalities. Norden also conducted a 20-year literature review of both case reports and case series of primary carcinoma of the fallopian tube. As a result of that, they were able to outline more appropriate patient characteristics, and they were able to hypothesize on the underdiagnosis of cases, what are the causes of treatment failure, and at the time they did the study, there were lack of controlled trials and usefulness of a second-look laparotomy for monitoring disease response to the treatment given. We looked at case reports of herbal therapy used by cancer patients, 18 reports with apparent anti-tumor effect, 21 case reports of toxic effect were identified. We found out that there were clinical trials in cancer populations in certain herbs like green tea, phytoestrogens, mistletoe, Ganoderma, Lysudium, noni, and silymarin. There were also some studies of saw palmetto, PC spares, dakenchuto, and many of the herbs with promising case report findings have either not been explored or the results were not reported in English. So we found that from this meta-analysis of case reports, only the characteristics and the case outcomes can better be assessed at this level of clinical research. However, in situations where there is no other adequate evidence, the best of the first line of evidence must be taken into account. What impact has case report had in medical research? The only thing I want you to focus on here is that case reports that were followed by published trials, only 17%, 83% didn't have any trials. And also when you look at the case series, the same thing. We find the same thing. 31% were followed by published trials, the remaining were not. Just higher because it's case series and not just case report. So how do you write a good case report? The CARE guidelines, this is case report guidelines, some very smart people came up with some guidelines, I think 2013. And these are their recommendations or guidelines that a good case report should have a title, keywords, an abstract, introduction, patient information, clinical findings, timeline, diagnostic assessment, therapeutic intervention, follow-up and outcomes, discussion, patient perspective, and informed consent. So what are my conclusions? That case report should be written in an organized and structured manner. It's still very relevant, I believe, in today's medicine. And in rare instances where clinical trials are not possible, for ethical reasons, case reports or series may be the only evidence available to recommend treatment. Thank you. I'm just acknowledging those people. Any questions?
So for case reports, are they more popular in Asian countries?
Yes, they are more popular in the Asian country, but it's getting better now, even in the western part of the world. You are now having, there seems to be a swing back into getting more case reports. Even some of the distinguished journals are allowing case reports. Most people are aware of the New England Journal of Medicine. Every week they have case reports that they discuss extensively. So yes, there seems to be interest back in case reports now.
Okay, I'll do it. Thank you.
Thank you very much. Thank you for waiting. Really appreciate it.